Thanks so much, Rachel, and everyone for inviting me today. Favourite birds? Well, that's a tricky one. So I've really got into birds since COVID, when we were in lockdown, couldn't go anywhere, and so we just sort of sat in the garden listening to all the birds. I had no clue what was what, apart from a robin and a blackbird, one or two other things. And I thought, I've got to find out. I've got nothing else to do. I'm going to find out what all these birds are, and it's kind of developed. And someone mentioned the snow bunting. I actually saw my first ever snow bunting, I think in Scotland a couple of years ago. I think we were in Durham, I think that's where it was. A lovely little white bird, really small, but very nice.
Very nice.
So let me talk about. I can get a window, if I can just get my slides up. Here we go. Share those. Full screen mode.
Looks good.
Yeah, looking good. Yeah. Okay, so I'm on full screen mode, so hopefully you can see that.
Yes, it's all fine. It's all fine
until I close it down at the end. So this is what I'm going to talk about today. So my way of introduction, yes, I'm a statistician, although I had a misspent youth as a medical student for a few years before I realised that actually clinical medicine was not for me, and statistics and epidemiology was. So I kind of converted, and that's what I do these days. And as Rachel rightly pointed out, I'm very practical as opposed to theoretical, and that will be reflected in my talk today. So I'm going to go through some key statistical methods for evaluating any healthcare policy. So that could be the rollout of some vaccine, some new surgical technology. Back in the day, we evaluated the use of laparoscopy, for example, in surgery, or the implementation of NICE guidelines. And I'm going to cover before versus after comparisons, interrupted time series, and statistical process control charts, all at a fairly high level. And I'm also going to cover along the way how to frame the research question, because of course, if you haven't framed the research question the way you need to, you're not going to be able to choose the right method of analysis. A little bit about preparing the data, but mostly about choosing the analysis and interpreting the output. As an academic, I always like to have learning outcomes for each session. So here's what they are. So hopefully at the end, you'll be able to know what are the main statistical methods for evaluating healthcare policy, understand the data requirements, strengths and weaknesses, and be able to interpret their output to decide how successful the policy has been. So this is going to be a high-level overview. I'm not going to go into formulae at all, and I'm not going to mention software. I tend to use SAS for most things, but obviously I know a lot of people use R, and that's what we teach, but I won't go into those kind of things. So first, evaluating the analytical question. By way of an example, I'll give you a paper that we did a little while ago on how people get diagnosed with heart failure in primary care. So the intervention here, if you like, or the policy being evaluated, is a NICE guideline for GPs to follow when they suspect somebody has heart failure. So what the guideline says that they should do is to order an echo and a particular blood test and refer to a specialist within 6 weeks of suspecting that their patient has heart failure. So we wanted to know how often does this happen, and also actually in whom. And this question is pretty broad, and it could be framed in different ways. And as ever, the devil is in the detail. So let's go into the detail to show you what I mean here. So here's the NICE guideline, and the bits in red are the bits where we have to make a decision. What do they mean? and how we're going to define them. So first one, should we try to identify that it's the GP that's done these things? We don't think that's necessary. I mean, in general, it will be the GP who's done them. And on the data, they may not be able to tell you exactly who's done what. So that's not a big deal in this particular case, but for your case, it might be. The echo and the blood test, there are codes for that. Oh, I can hear a bit of feedback. There are codes for an echo and blood test, the BNP blood test. So that's straightforward. But referring to a specialist, so what does a specialist mean in this case? How would you define one?
And now I'm all right, thank you.
That's 390.
And what do you
So
do?
I'm just going to jump in. Could everybody on the call, could you just mute yourselves, please? Sorry, I can't see, but I think I suspect somebody isn't muted. So if you could just mute, that'd be wonderful. Thank you very much.
Cheers. Yes, and what's a specialist mean? What if the GP only did the echo and not the other bits of the guideline? And the biggest question of all that we spent most time thinking about, how do we know when the GP suspected that the patient had heart failure? What symptom codes should we be looking at, and when were they recorded? So that the symptoms for heart failure are pretty general, tiredness, shortness of breath, swollen ankles. Patients come and see their doctor with these things all the time, and lots of them don't have heart failure. But what if no symptom codes were recorded at all? Often they get put in free text in primary care data. Or maybe the GP has a working definition, working diagnosis, suspects they've got heart failure, and they try them on, they say, a loop diuretic to try and get the swelling down, first of all. Maybe that's when you should count suspicion of heart failure. So what we did, rightly or wrongly, is we divided patients into whether they had coded symptoms and treated each group separately. We did a 5-year look back in the data from the heart failure diagnosis, and the diagnosis date was taken as the first recording of that heart failure code anywhere in the data. So this was CPRD, so it's linked to primary and secondary data. 80% of those were recorded in HES data, and the other 20% in CPRD. I'm going to assume you know what HES and CPRD is, but if anyone doesn't, just shout. So this is not perfect, but it was a practical way, and the reviewers of the paper didn't seem to mind. We also took the first symptom in those 5 years as the patient's first presentation to primary care with early heart failure. So that isn't going to be perfect either, because you could go to your GP with those symptoms for something else and it's not heart failure, and then later on you develop it with the same symptoms, but it's really hard to tell. So that's what we did. And in terms of guideline compliance, we defined total, full guideline compliance, partial if you only did one bit, and 0 if you did none of it. Headline figure, full compliance, pretty low. That's only 7% of GPs did the full Monty in the 6 weeks. So let's go through some general data considerations. So data sources that you will be familiar with, so electronic health records like CPRD, but you might also be able to access your local hospitals' EHRs. Registries, we've got patient surveys, staff surveys, and we've got a lot of administrative data sets. Thankfully, I use, say, HES and ONS mortality in particular. Depending on what your project is, you're going to need either patient consent or put in an HRA application through IRAS, and there may well be many more committees you have to appease in your attempts to get hold of the data, as I found very recently. And there may be issues around reporting. For instance, you may have to suppress small numbers depending on your data sharing agreement, etc. Kind of variables you want in your data, you're always going to need some demographics. some diagnoses and treatments. Particularly, this is going to be defining your denominator, your set of people that you're interested in. Some measures of policy success, what you're evaluating. The policy change dates, of course, you need to know when the policy started and any potential confounders. Those of you who are analysts will spend a lot of your time doing these kind of things, removing duplicate entries and deciding what to do if somebody has more than one date of death recorded, for instance. Choosing your ICD-10 or other codes, SNOMED codes, etc. Managing missing values, whether you're going to be just deleting the case, deleting the variable from your model, or trying some kind of imputation. And making sure if you need to do longitudinal linkage, that you're able to do it in your data. If you can do patient IDs match, are they there? Have you got also NHS missing numbers, etc. And some data quality checks. So are long-term conditions recorded in each record that the patient has? Have there been any validation studies on the accuracy of your data that you're looking at? I do some work on COPD in primary care, and my colleagues have done exactly that. They've got the GPs to assess how accurately their COPD diagnosis is and acute exacerbation codes are, so super important, and some basic plausibility assessment for checks. Hopefully you don't have too many blood pressures of 20, whatever. And again, you have to choose the right format for your analysis. Some packages, some methods want the so-called long data where you've got multiple rows per patient. But for what we're talking about today, most it's going to be aggregated data. So some general methodological challenges. I'll just talk through these in general before I illustrate all of these things really with when it comes to the methods. Confounding is going to be a big one for us today, particularly thinking about looking at time trends or in co-occurring interventions, which can really scupper your interpretation of your analysis, and changes in patient characteristics over time, or differences in patient characteristics between your intervention group and your non-intervention group. That's of course a big deal. Has the policy that you're evaluating been adopted sort of in some kind of non-random way, or only in an incomplete way, or a bit, and then you lose track of people? These are problems, although you might argue that an incomplete compliance with a given policy, a rollout, it reflects reality. So that's kind of like an intention to treat analysis in a clinical trial. So you're analysing or evaluating the policy as it's been rolled out, not as some perfectly rolled out policy. You'll be familiar with the joys of inaccurate coding, diagnoses, or diagnosis coding in particular, but other things, dodgy blood pressure values or whatever. Or thinking that you've got your control group has nobody affected by the policy in it, but actually it's misclassified, and I'll talk a bit more about that later. And then generalizability, we're always concerned about this in our analysis. How applicable are our findings to wider populations and settings? Now, that might not matter if you're evaluating a particular policy that is not implemented anywhere else, particularly, let's say, even like a national policy that's done in this country. Maybe we don't not bothered about whether it works in China or not, for example. And have we got enough statistical power for again? So that is important for these kind of methods, just as it is in clinical trials, etc. So next thing is we want to choose the method of analysis. This is the bulk about what I'm going to talk about. So it's simple before versus after, extending that a little bit to so-called difference in difference. or controlled before versus after comparisons, interrupted time series, and SPC, including fun plots. So first up, simple before versus after. So for instance, did the GP compliance with the guidelines improve after some publication of the plan to improve cardiovascular diagnosis, such as in the 2019 NHS plan? So that would be, we might do a before and after there. So you need to define your 2 time points, which might be the first year after publication of this plan, compare with the year before, for example, but other choices are available. How are you going to define success? So in this case, we've got the elements of that NICE guideline that I mentioned earlier. So those are metrics of success. We operationalize as in with the codes, as said earlier, and choose what kind of confounders, what might change in our population over time that could confound any apparent effect, like age and sex, etc. But we might also be interested in any inequalities. So maybe the guideline has improved things for younger people, not for older people, or men only and not women only, for example. So we may want to consider that. And the good news for this design is that the analysis is a doddle, so it can just boil down to a simple chi-squared test, or some kind of regression, or t-test if you're just comparing means. It can be as easy as that. So the good thing about this is it's simple, particularly if you're not worried about confounding or you don't think there is any. It's certainly quick, particularly the analysis step, and it is naturally suited for a lot of clinical audit studies, particularly say before and after you've made some kind of improvement in hospital or your practice. But that's it really, because there are a number of issues with this that you may be aware of. So it's really susceptible to regression to the mean. So if people are enrolled in a quality improvement program with when they've got really severe symptoms, or so HIUs, high impact users, people who go to the A&E a lot, and you enroll them at the time when they're using A&E a lot, you can find that a year or 2 years later, their use of the ED will just naturally go down. It will naturally, or their patients with severe symptoms may go back to normal some point afterwards, because that's the nature of the disease, and you're going to get regression to the mean, and this approach can't handle that. There's no control for pre-existing trends, so that's pretty heroic assumption that there aren't any. There's no control for seasonality, and there's no control for external influences. So there's quite a lot against this. So can we do better? Well, we can do better with the difference in difference approach, and we extend this simple before versus after comparison to include the control group, and that's why it's also known as the controlled before and after design. So it's the same kind of thing, but with a added control. And this time, the counterfactual that we're comparing the after bit against is based only on the control group. So we are assuming that the control group and the intervention group have the same pre-intervention trends. And if you've got the data, you can test that assumption, and indeed you should test that assumption if you have the data to do it. So that's the parallel trends assumption. So that's a difference in difference. This is pretty common in health economics, but also just in stats. So as an example, this is not my work, it's work from Naomi Phillip and co. Some years ago, stroke services in England were centralised into so-called hubs and spokes. There was a big reorganisation in London with some hyperacute stroke units and some other normal units, if you like, In Manchester, they had 3 hyperacute stroke units and 11 other ones, but set up in a very different way. I won't go into details, but very different kind of hub and spoke. And then the rest of it, England was not reorganised at all. So the question they were trying to answer was, did this reorganisation work? And indeed, of course, why? So there was another qualitative component that really went into the why bit, but we're just talking about quant today. So what they did was a controlled before and after design to compare sites pre and post centralisation in terms of various things. So they defined success as some clinical outcomes like mortality, delivery of certain clinical interventions that are relevant for stroke, and also cost effectiveness bit as well. But they also did comparisons with the rest of England. So they combined different bits of analysis of before and after. Basically, it was London before and after, Manchester before and after, but also London versus England, Manchester versus England. And some results for London, for example, that they found that London was significantly better than the rest of England in terms of mortality. And indeed, the lengths of hospital stay were shorter as well in London compared with the rest of England. They then extended the analysis of the data to March 2016, so a few more years of data after that initial before versus after study, and they found that these improvements were sustained. So that helps to convince us that it was the reorganization of services that had this impact, and not some other thing that was going on, some other initiatives or reorganizations or whatever that was going on at the same time. Next up, ITS, interrupted time series. So here you've got data at regular intervals. You probably have patient level data, but then you aggregate them to regular intervals. For instance, you can look at monthly guideline compliance, and this is for the intervention group only. You explicitly model both the pre-intervention trend and the post-intervention trend, and you test for a step change at time t0, so when the intervention happened or when the policy was implemented. So in this case, it's not just the pre-intervention period, it's the pre-intervention trend serves as the counterfactual, and that's what you're comparing any post-intervention levels against, the pre-intervention trend. Because it's time series, you need to check for autocorrelation. So the idea that data points close in time might be correlated more than points further apart. This isn't always a problem. So certainly I've not had to do this very often when running ITS, but you need to do it. And those of you who are technically minded, you may know that you want to do the autocorrelation function plot, and there are some specialized residuals for looking at this called Durbin-Watson ones. And if this is an issue, then you can fit what's called an autoregressive integrated moving average plot if there is some correlation found. Basically, you can't ignore this correlation. You've got to deal with it, and then you base your trends after you've dealt with it. Plotting the model trends is certainly easier. It's easier to interpret than just giving the coefficients, but you want to give those too. I'll show you an example of that in a minute. Actually, I'll show you. I thought I had a plot. Okay, I'll come later. So there's some advantages to this. So it doesn't have a control group. You are looking at before versus after, and no control group means that you don't have to worry about whether your two groups are different in some way, which can be complicated. And modeling the underlying trend, which the simple before and after doesn't do, controls for a whole host of problems. So it controls for things like your patient characteristics that only change slowly over time, for your secular time, pre-existing time trends, random fluctuations, one points, and all sorts of important issues like that. On the other hand, it's more complicated than before versus after. It also can't deal with when other interventions or events occur around the same time. But you can that's good reason for adding a controlled group, and that gives you a controlled ITS. So if you see an effect in the intervention group, but you don't see one in the control group, it strengthens the idea that actually it's the intervention that's improved things. So what you should do to do a controlled ITS, start by analysing the two groups separately, so your intervention group and your control group separately as their own ITS. Then you model them together as a controlled ITS, and then compare the two, and hopefully they agree. If only the uncontrolled ITS shows an intervention effect, then you want to suspect some simultaneous event. If only the controlled ITS shows an intervention effect, then suspect that what's gone on here is that there's been some change in the control group over time, because some event has affected the control group and not the intervention group. Now, this is probably easy to understand via a plot. So this is taken from not one of my papers, another one, showing a controlled interrupted time series. So on the left, well, on both plots, you've got the solid line, the red line, that's the intervention series, and the dashed line, the green line, or if you're colorblind, it's the top line is intervention, the bottom line is control. Where the plot on the left, plot A, shows that there's an effect in the intervention group only. So you can see that before the intervention, you've got two trends, and the top line, there's a drop at the time of the intervention, and then also the slope changes, whereas in the bottom line, the control group, carries on its merry way and just keeps going along the pre-intervention trend. So that's what you hope to see. If, on the other hand, you see B, where the intervention group does the same thing as the control group, then that suggests that there's some other event going on. It's not your policy or your intervention that's at work here. It's something else, because it's affected the control group as well. So this is a really important kind of plot to do. It really helps us understand what's going on. A few thoughts on this. It's a good idea in general. It is a good idea if you can. It may not always be possible, though. If you've got a national rollout or financial crisis affecting the whole country, it may not be possible. So you'll have to do an uncontrolled ITS. But you can still consider a so-called control outcome, so one that you think is unaffected by the intervention. Now, that's quite common. Now, the ideal control group is the same in terms of all the variables other than exposure to the intervention. And there are ways of making different ways of making a control group. There's propensity score matching and synthetic controls, which I haven't got time to talk about. But all these aim to give you the ideal control group in terms of at least the measured variables you emulate. There are some issues with control groups, so you don't pick one that's exposed to events to which the intervention group is not exposed. That's if you know that that's the case. And both groups need to have similar susceptibility to whatever intervention it is. So try to match your patient factors throughout study period, not just at the intervention time. And you can get all sorts of effects. So like contamination effects, if you're evaluating, let's say, a new policy in general practice, where you've got some GPs are supposed to be following it and other GPs who are not supposed to be following it, but they hear about the intervention and think, oh, that's a good idea, maybe I'll try it too. That's going to be, contaminate your intervention and bias your effects towards the null. Some other things to consider with ITS is that it includes a linear trained estimation, so you're going to need at least 5 time points to do that. If you don't have that, then you may need to reduce it to a difference in difference. If you're modeling counts as opposed to means, then look for over-dispersion. You're probably already used to doing this. But some options for over-dispersion when you've got a lot more variation than expected under, let's say, a simple Poisson, is model with a quasi-Poisson, negative binomial, assuming a gamma distribution or some transformation of other things. Again, that's quite a big topic that I haven't got time to talk about today. You should do some sensitivity analysis on your choice of control group, and you should specify those in advance. Otherwise, you can be accused of data dredging. And COVID, as ever, really mucked things up for our analyses. So what do we do if you're trying to evaluate something that occurred before, during COVID? Well, you can try and segment your time period, your time, looking at before COVID or maybe an after COVID. Or if it straddles COVID, then we tend to just exclude the whole COVID period and pretend it never happened in terms of estimating your ITS trends. You should also look for unintended consequences. So here's an example of some of what we did. This is going back in time, Bristol Royal Infirmary inquiry. So this is mortality following surgery for congenital heart operations. At Bristol, that's the top line in blue, versus the other specialist centres. That's the bottom line in red. And when the two surgeons at the centre of the inquiry were struck off, you can see the blue line mortality at Bristol plummeted in 1995, 96. But it's important to consider another way of reducing your mortality after surgery, and that is not to do these risky operations at all. So it was important for us to check that people were still doing the operations, and that's the black line. And it turns out that they were still doing these operations. It's just that everyone was getting better at it. So that's a good news story. Okay, the last thing I want to talk about, conscious of time, is SPC. So these were created about 100 years ago now by famous Walter Stewart, who was hoping to improve the reliability of telephone equipment at Western Electric Labs. And he develops a way of distinguishing between so-called common cause variation and special cause variation. So common cause variation where a process that is in control, that is showing just random variation. So there's nothing wrong with the process, the manufacturing process in his case, but it's just, it's going to vary a little bit. Versus so-called special cause variation, where something has gone wrong with the manufacturing process and you've got an outlier, basically. Very influential, spread to the US Army during the war, and of course post-war Japan. We are familiar these days with the Toyota's total quality control, total quality management process, and Six Sigma, all that stuff. That came out of Stewart. And it tests for deviation from some expected performance level. And it avoids making this error. So Rachel mentioned this making data count guide. Here's a plot of average waiting times over time. And this comment at the bottom that management has come up with, oh, they're worried because waiting times declined this month, i.e. the mean went up, which it looks like to naked eye on the right there. Of course, SBC in this kind of chart tells us, no, it didn't. It's just random variation. Don't panic, it's fine. So what you want to do, you collect regular measurements, could be monthly or weekly, or even daily, depends what you're looking at. You calculate a central line, which can be the mean or the median, and control limits within which you say, okay, this is expected variation. We're happy with anything variation that occurs within these two limits, and that's typically set at plus or minus 3 sigma or 3 standard deviations of the process. The one or two charts do some other things, but as I'll show you. And then you plot the values and you flag points outside the control limits or any unusual pattern. And then that's the simplest one. There are also other rules to detect different changes in trends, etc. So here's an example that compares the simple run chart on the top with Stewart's own chart at the bottom, which has the control limits. So at the top, this is the simplest thing of all. You just plot your this example is percentage of unreconciled medications in hospital, and you just plot the numbers over time. And there are some rules for noting when there's a problem. You've got 8 consecutive points all going in the same direction. That defines a trend, for example, in a run chart. But it's a bit that's simple, but it's limited. So one thing, of course, it doesn't tell you whether you've got any outliers at all. And the Stewart chart at the bottom puts control limits on, and lo and behold, you've got point number 8 and point number 19 are above the 3 sigma line. So those are unusually high, those two data points. There are loads of chart types of chart here. Run chart and Stewart charts I've mentioned. Run charts are easy, but they can't really spot any special cause variation very well. Stewart charts, on the other hand, can, but they can only spot these big jumps, so single points that are out of control. They can't spot trends or smaller changes. P charts are for proportions. You may use these quite a lot. Your proportion of the thing that you're interested in, such as hospital infection, might be rare. So there's another one called a G chart, which monitors the time between events, and that's apparently more sensitive. The XMR chart, individual moving range, this is particularly good if you've only got one observation at each time point. Perhaps there is only one observation possible, or you don't have the individual level data, and that's super versatile. QSUM charts, and funnel plots, I'll show you these in a second. QSUM charts are really good for small changes. Now, sure, it's good for big. QSUM's good for small changes over time. And a funnel plot we use these a lot, is good for comparing multiple units, like general practices or surgeons or hospitals or whatever, against the same benchmark. Back in my days working for the Harold Shipman inquiry, this is where we were interested in mortality. Which practices had high mortality, and could we have detected the Harold Shipman earlier? And here's his chart, and the answer is yes, we could have detected him a couple of years earlier, but we would have detected a whole bunch of other GPs at the same time. By the way, these were all investigated, and none of them were found out to be serial killers, just in case you were wondering. So that's looking at raw data for QSUMs, but you can risk adjust QSUMs, and this is what we did with our long-standing collaboration, Dr. Foster Intelligence, where we had a national monitoring system of mortality in hospital using HES data, where we risk adjusted people's chance of dying to make fairer comparisons between each hospital and the national average. And again, these charts, they kind of potter along. When a patient dies, the chart goes up. When the patient survives, the chart goes down. And if the observed is greater than expected by such a big amount that it crosses the threshold, here's the alarm, like it did here in sort of just after January 2008. And then hopefully you're going to investigate what's going on there. Last plot I want to mention is that the funnel plot. Here's one from our paper some time ago, where we plot the volumes of the number of finished consultant episodes along the bottom and the day case rate for hemorrhoidectomy in this particular case up the side, and each dot on the plot is a hospital as an institution, and you can see that some are above the upper lines of 3 SD lines and some are below the lower lines, the 3 SD lower lines, and that shows that in this case a lot of between unit variation. Some considerations for control charts. How many data points? Well, you do need a number. If you don't have at least 15, you may be stuck with doing a run chart, or even just or going back to a kind of simple before versus after. I won't go into recalculating the center line, but because the NHS document has got quite a lot on this. And what do you do if you want to monitor multiple metrics? So your choices are a separate SBC, one for each metric, create some kind of composite metric with all the pros and cons involved in composites, or there are quite complicated methods called multivariate SBC. So if you've got correlation between your metrics, you can make use of that correlation with a multivariate chart. Maths is quite complicated, and I won't go into that today. So lastly, that's a kind of whistle-stop tour through a lot of methods. So I've got a question for you to finish up to see what you make of this one. So this is a study that we did some time ago, looking at the effect of vaccinating against bacterial pneumonia in children, PCV7. So it's a new kind of vaccine that deals with a lot of strains. And we wanted to know, did it actually reduce the number of bacterial pneumonia admissions in children at a national level, because it was a national policy. And it was introduced in September 2006, and here are the results. Hopefully, next slide will have a Mentimeter thing for you to actually type in. I hope it works. But I'll just give you a few seconds to think about, before I even give you the options of what you would do. How would you assess whether this policy has worked? Just give you a few seconds to think about some potential options. Oops. Okay. If this is working, and it might not work. Excellent. So I'd be grateful if you could, hopefully scan that, and hopefully that will work, and pick your option. So would you do a before versus after comparison? Would you do an ITS? Would you wait until you've got more data and do an ITS with 5 more recent years? Would you do a Shewhart chart? Would you compare England with Wales and do a difference in difference? So it's a kind of controlled before versus after comparing against Wales. Or would you do something else? interesting. Just give another few seconds. So far, the ITS with 5 more recent years is winning. But there are also some thoughts about doing a simple before and after, or comparing with Wales. Nice. Okay. So thanks everyone. That's quite encouraging, actually. Before versus after, that's what we did. We didn't have any more data, any more recent data. ITS is not, we don't have enough, or didn't have enough data points to look at the post intervention. There wasn't enough to measure that post intervention trend. But waiting for, if you can wait for a few years, you get more data, more time points. That's a good option. Short chart is not very sensitive. The DID is a good option if you have the data in Wales, assuming Wales didn't do the same rollout. That's also a really good option. You could do, instead of annual data, you could do quarterly data to give you more time points, but that's going to be noisy. I'm sure there are other options that we can think about. So some final thoughts. Our approach to what you do is determined by how you frame the question, by what data you've got, by the choice of a suitable control group, if there is one, which there might not be, and is in the interpretation. And I'd argue that the wrong control group or benchmark is worse than not having any at all. Should you be using SPC or should you be using ITS? Well, SPC, as you know, is particularly good for quality improvement. But if you want to know the effect size and perhaps subsequent economic evaluation, you're going to need to do an ITS for that, like the stroke reorganization study, for instance. Well, that's all I have. Thanks for your attention. You can get in touch with me at that email address. Connect with me on LinkedIn or I guess by Rachel. Well, I'm happy to have these slides sent out to you afterwards. But I think I've gone a little bit over time. But hopefully that's been useful. Thanks so much.
That's wonderful, Alex. Thanks. Thank you very much for taking us through that. I think you've shared so much information and hopefully inspired people to think about different ways that they can actually review and sort of evaluate some healthcare policy or something that's in front of them, and give them some clues as to where to start at the very least. So that's been really helpful. We haven't got time for loads of questions, so I can share them with you after, if that's okay. But if I could just on Slido, there's just a couple. So I'll pick the hardest, obviously. So I can see you like a challenge. I'm just kidding. I won't share my screen. If it's okay, I'll just sure. Read out a couple of them. So, and I think this one, which I'm about to read, I think you've covered this. So. The person here is asking, are there simple steps that you can take to choose the right approach? So not everybody is as experienced as you are, and they may be sort of coming to this fairly new, or they're just coming to it with feeling they lack confidence maybe in what to do first. So they're presented with maybe there's a pilot, which is quite often that happens, and the data isn't perfect, Alex, and that's almost the case. Where would you start with that?
So it always start by plotting the data. You want to plot your trend first of all without assuming any trends at all. Plot the data on that, like that kind of bacterial infection plot that I showed, which is just showing the time trend, will align with the intervention where you think it is, because that will tell you how many data points you've got, and that, because that determines what your analytical options are. Have you got enough pre and post to fit a trend, or is the variation in your pre and or post too big to fit a robust trend, which it might be, and you can only work that out by plotting the data. So that's always going to be the first stop, and then you may end up having to do a before versus after, or controls before versus after, if you've got a readily kind of available and kind of obvious control group. Control groups can be difficult to think through, but that's always going to be the first thing for each of your measures of success that you're interested in. But I would also try and think about, or get the team to think about, so-called control outcome. Even if you haven't got a control group, control outcome, what could you plot that you don't think the intervention will affect, and plot that as well, because if you see a change in that, then you know something else is going on. So that's a brief answer. Yeah,
no, that's great. So we have hit time, so I haven't got time to go through the other points, but the other questions and comments. But I will share them with you after, Alice, if that's okay, because there's one or two I think would be really useful. And somebody's also shared a resource that would help people as well on GitHub. One of the questions, and I'll leave this with you, starts with surely, so that means they're challenging. I love that. Thank you, challenging question maker. As I say, I'll share that with you afterwards.
Yes, I'll be happy to respond, and if you want to pass back my answers, that'd be great.
I will. I'll just last 1 second, unless hopefully you're not rushing off everybody, but it's okay if you are, because we're recording these and we can share these with you after as well. So just what's coming up is not that. What's coming up in the next few huddles. So we've got the colleagues from the Isle of Wight are coming up next, and they're going to be talking about a very different topic, which is the domestic abuse strategy, which they created the evidence for, and we're going to be talking about and sharing the dashboard and so on, which they've created on the back of that. Then we're going to be switching back to a more technical session, but with just an introduction to R. Alex mentioned R earlier on, so we know there's a big appetite for people to start to learn it, for those who aren't already well versed in those techniques, because there's lots of tools and lots of apps that you can use which can help you do your work, and certainly in stats I think it's particularly useful. Then we have a session from our colleagues in AFA, and we're going to be looking at the introduction to their specialist networks, of which there are many. Then we're going to have a session, not date to be decided, about knowledge mobilisation. So we have a really great range of topics coming up. That's with strategy unit Alison Turner. Hope she's not on the call, because I haven't asked her yet, but I know it's going to be a great one. That is to be confirmed, Alison, in case you are on the call, and lots more besides. So I'll just come back to you to just stop sharing. So thank you again, Alex, for coming. I really enjoyed today's session. I can't wait for you to come back again, because there was more on the choice of things that you could talk about. And thank you everybody for coming as well. Great to see you all. My Alexa is talking, and I'll see you in a couple of weeks. Thank you everyone. Bye bye.